Good morning everybody. I am Dr. Nitin Joshi, Professor in Urology with teaching experience of 25 years, working as consultant neurosurgeon in Panvel for more than 25 years. Today we will see role of bone-seeking radiopharmaceutical agents in bone-targeted therapy. It is asked as a theory question. It can be a part of bone-targeted therapy as well as it is asked in case discussion. The advanced CA prostate progresses to metastatic cancer prostate. Bone or skeleton is the most common organ involved in metastatic disease. It is due to the theory of or concept of bone and seed soil. According to this theory, the osteoclasts due to osteoclastic activity are responsible for providing the chemokines, that is chemotactic factors and surface adhesion molecules to cancer cells. Due to chemotactic factors, the cancer cells target the bone, and due to surface adhesion molecules, cancer cells penetrate the bone. The cancer cells has got strong affinity for the bone matrix, which is the storehouse of immobilized various growth factors which are actually synthesized and deposited by the osteoblasts for their growth. Cancer cells, on arrival to the bone, they provide various osteoblastic and osteoclastic factors to the bone. Due to increased osteoclastic activity, there will be resorption of the bone. Due to resorption of the bone, there will be release of this immobilized various growth factors which are present in the bone matrix. To these various growth factors, even the cancer cells are sensitive. This results into sudden proliferation of the tumor cells, causing progression of the disease, resulting into multifocal mates in the bone. Also, in case of cancer prostate, there is tendency to involve axial skeleton, particularly vertebral column. The tendency to involve the vertebral column or the spinal column in case of cancer prostate is due to spread through Batson plexus. The Batson venous plexus, it is a valveless perivertebral veins which connect the deep veins of the pelvis and the thoracic veins to the intraspinal venous plexus or internal vertebral venous plexus. The prostate cancer cells spread through periprostatic venous plexus of Santorini into the internal iliac vein, and from the internal iliac vein they pass through Batson plexus into the internal vertebral venous plexus, thus producing metastatic lesion in the spinal column. The vertebral bone which is involved by metastatic lesion will be destroyed. Because of destruction, there will be collapse of the vertebra, hence postural change, severe interactable low backache, spinal cord compression and neurological deficit. The most common cause of increased morbidity and mortality in case of advanced cancer prostate is skeletal involvement, causing skeletal related events like interactable bone pain, pathological fracture, change in the posture, decreased mobility, decreased quality of life, increased morbidity, cord compression, neurological deficit, and hence the concept of bone targeted therapy, so as to either prevent the skeletal related events or delay or postpone the onset of the skeletal related events and decrease the frequency and severity of skeletal related events. Bisphosphonates commonly used zoledronic acid, then denosumab, which is rank inhibitor, that is receptor activator of nuclear factor kappa B inhibitor, and radiopharmaceutical agents, which are bone-seeking radiopharmaceutical agents, together constitute bone-targeted therapy. Studies have shown that the use of zoledronic acid, which is a part of bone-targeted therapy, can be used even in setting of non-metastatic castrate-resistant prostate cancer to prevent the onset of metastasis in the bone or prolong the interval for the onset of metastasis in the bone and delay the onset of first skeletal related event. Now the concept of bone seeking radiopharmaceutical agent. External beam radiotherapy is effective in the palliation of bone pain, promoting healing of the pathological fracture, preventing impending pathological fracture. However, this is possible if the lesions are focal, but in case of cancer prostate, bone metastatic sites are multiple, and then the treatment with external beam radiotherapy is difficult. Also, external beam radiotherapy can treat the lesions which can be detected radiologically. The lesions which cannot be detected radiologically cannot be treated by external beam radiotherapy. Also, external beam radiotherapy treats or not only the pathological, but it also affects the surrounding normal tissue, and hence the incidence of side effects are more, and hence the concept of bone seeking radiopharmaceutical agent. In the normal bone, the bone mineral, the main bone mineral is the bone mineral salt is calcium phosphate and is typically in the hydroxyapatite crystal. The normal bone also contains other bone salts like calcium carbonate, magnesium carbonate, potassium carbonate, sodium carbonate, but they do not crystallize, but they remain adsorbed to the hydroxyapatite crystal. Similar to these salts, even the foreign salts like strontium, samarium, radium can be injected intravenously, and since they have got strong affinity only for bone, they enter bone and then they remain adherent or adsorbed to hydroxyapatite crystal. As a result, these salts, strontium, samarium, radium, they remain in the bone, and the strontium 89, samarium 153 and radium 223, they have got radiological activity, radioisotopes. They emit alpha or beta particles, and thus by radiation they kill the tumor cells. So there are two bone seeking radiopharmaceutical agents, either alpha emitters or beta emitters. FDA has approved the use of beta emitters, that is strontium 89 and samarium 153, in the palliation of bone pain in metastatic castrate resistant prostate cancer. Though the strontium 89 and samarium 153 causes bone pain palliation in metastatic castrate resistant prostate cancer, studies have shown that use of this, there is no overall survival. The beta emitters of the strontium 89 and samarium 153, the depth of penetration by these beta particles is long, that is the path length is long. The depth of penetration is more, it is in terms of few millimeter, and this results into the suppression of bone marrow and hence myelosuppression. Samarium 153 as well as strontium 89, they concentrate in osteoblastic activity. The CA prostate metastatic lesions are osteoblastic, and so if there is increase or extensive metastasis in the bone, then the uptake of strontium, particularly of strontium 89, will be more concentrated in the osteoblastic type of bone mates, and so there will be more bone marrow involvement, causing bone marrow suppression, fall in the WBC count and neutropenia and neutropenic fever, as well as anemia. So at the same time, the Sumarin, as compared to Sumarin, the strontium has got longer half-life of 4 to 5 days, while Sumarin has half-life of 1 to 2 days. But both having the side effect of myelosuppression. So as per the guidelines, recommendation is that the treatment with strontium 89 or Sumarin 153 is to be withheld if there is prior myelosuppressive treatment with radiotherapy or chemotherapy in the patient within 6 weeks. In contrast to these beta emitters, the alpha particles emitted by radium-223, their depth of penetration is short distance. So the path of penetration in the bone by alpha particles is only few micrometer, less than 100 micrometer, and so the side effect of bone marrow suppression and myelosuppression is significantly lower than beta particles. The beta particles, their production of the ionizing radiation energy is low, so the biological effectiveness is also low, and so they require 100 to 1000 hits for cell death. In contrast to this, alpha particles emitted by radium-223, they are 7000 times heavier than beta particles. Their ionizing radiation is dense, and so they require 1 or 2 hits to have cell death. Studies have also shown that the use of radium-223, it not only causes palliation of bone pain in metastatic castrate-resistant prostate cancer with bone mets, but also they have shown overall survival benefit. Now, what is the significance of markers of bone turnover in bone targeted therapy? There are well documented markers of bone turnover. For the osteoclastic activity, there is urinary measure of entelopeptide, while for osteoblastic activity there is serum bone specific alkaline phosphatase and protein osteocalcin. They have got prognostic significance. That is, studies have shown that patient whose markers of bone turnover have been normalized by treatment with bone targeted therapy have got better prognosis in terms of recurrence, progression and overall survival. The endpoint of treatment with intravenous bone seeking radiopharmaceutical agent is 1. Reduction in the pain score by 1 level, reduction in the requirement of analgesic, improvement in the quality of life and performance status. Today, though the bone seeking radiopharmaceutical agent is the standard of care for patient with bone metastasis with significant intractable bone pain in castrate resistant prostate cancer for palliation of pain, still this IV bone seeking radiopharmaceutical agent cannot treat the extensive soft tissue metastatic lesions and also neurological compromise. In this setting, still external beam radiotherapy is the treatment of choice. Thank you very much.